All right. Well, thanks so much for having me. I am really happy to have the opportunity to talk about why this is so important. This is a clinical conversation, a practical conversation. This is not the same from your risk management association where they're telling you got to do it, you got to check the box. This is really about understanding why it matters to you and to the people you care about. You have devoted your professional life to your practice and your patients, but what happens to them if something happens to you? None of us wants to think about it. Some of you may be thinking, I'm healthy, I don't need to worry about this for a long time. Others may feel guilty that you have been meaning to make a will and haven't gotten to it for 15 years. That's a pretty common story that I hear. Um, it's overwhelming and we are only human. So, we're going to focus on the importance of this today. This is not about being paranoid, it's about being prepared. And it's an extension of our clinical care for our patients. So, when my closest colleague and psychologist, friend, and supervision partner of 17 years faced a crisis, she taught me a lot about courage and grace in dying. I had a crash course in planning, in grief notification, the details of dismantling a practice. I did learn that being a practice executor is primarily a clinical role. It is not administrative, which I think many of us are led to believe. Um, and finding templates on the internet and making partner agreements with colleagues, it is really selling ourselves short, our families short, our colleagues short. And it's about not really understanding what responsibilities follow a sudden practice closure. So part of my thoughts as I did this once for one friend, then again for another friend, then started writing and teaching colleagues on this topic, what you need to do as a practice executor, and therefore what needs to go in a professional will to help someone who would be doing this for you. Um, it really has come to the question of like, why do each of us need to figure this out ourselves in our office in a do-it-yourself model? We share this ethical obligation, and so promoting education on this is also about promoting resources to be able to solve this in a less difficult way than I think most of us feel it needs to be. So I also want to say we pride ourselves as therapists in our emotional bravery. We explore countertransference, dark humanity, shame, rage, disgust. We sort of think, yeah, we can sit with it all. But when it comes to our own mortality, still no go. We don't want to face it either. So part of this is, what do we owe our patients and how can we extend ourselves another step further? And we are only human, and the weight on our shoulders can be significant, and we are not able to predict everything that happens in life, and certainly our patients can't expect that of us, but they can expect that we are conscientious, that we are planful, that we can predict if something happened, what it might be like for them, which is pretty shocking and um, difficult, stressful, painful. And so, what do we need to put into place just in case? So, I do want to disclose I have a conflict of interest in that I have derived out of these presentations, created a service called TheraClosure to solve for this. So I do stand to benefit. I am going to focus on the ethics and the responsibilities here. So I'll let you kids in, but you're going to have to pay taxes and deal with your own mortality. We have to do it. We don't have a choice. So think about, do you believe your clients are attached to you? You can nod. And if you're able, I would love it if you turned your cameras on. It's much nicer to feel like I'm engaging with you than a dark screen. I don't mind if you're eating lunch or multitasking or petting your dog. It's fine. Oh, thank you. Thank you, guys. So if you believe your clients are attached to you, give me a nod. And do you care about your clients? Give me another nod. I know you do. When I talk with therapists, that is the primary sentiment that they share with me, deeply caring about their clients. So then my last question is, are you going to live forever? No, no. Some of you might want to say yes, but the answer is no. So how do you take care of people you deeply care for who are deeply attached to you? That's what we're talking about. So it's really about preventing traumatic terminations. That is what this conversation is about today. So, what if you suddenly disappeared? What would happen on Monday when your scheduled clients show up on Zoom or in your office? Take a minute and really think about it. We kind of blunt how far we will go in considering these issues, but let's dig in a little bit. What would happen? You may want to jot down some ideas that come to mind for you. Who would greet them? What would happen if you never got on the Zoom call and they called you and they emailed you? Who's going to see those messages and reply to them? Who's going to meet them in the waiting room? Who's going to see them when they're knocking at the door of your suite and nobody's letting them in? What's going to happen? So think about it from your own perspective. What if your therapist suddenly disappeared? How would you feel? I can tell you yesterday, I called 10 patients of a therapist who had suddenly died. And the patients, one after another, said to me, "Oh my God, I can't believe it. I can't believe it. What am I going to do? He was such a wonderful man. I've been with him for 20 years, for 10 years, for 5 years. What am I going to do?" And the um, intensity of sitting with them as they try to grapple with that is a lot. It's painful and important because mourning your therapist is not a typical socially sanctioned, acceptable kind of experience and relationship. You don't go to work and say, I need bereavement leave. My therapist died. People don't get that or talk about that in that way, but that's what these people are experiencing often. So think about yourself. The golden rule always helps us. And what would help you to feel you had been as compassionate and conscientious in your absence as you try to be as their therapist? Think about that. It's one more step that's consistent with all the other things that you do every day to treat your patients with good care. So you bear with me here. This is a long quote I'm going to read to you, but it touches on a lot of the threads that we're going to try and unravel today as we go. So there was an article on therapist loss in the New York Times this summer, and in the comments section, someone wrote in, "My therapist passed away in the summer of 2023. His poor wife was the one to call me and break the news. She seemed surprised I hadn't seen the obituary in the paper. She said she'd email me the name and contact info of the person taking over his patients, but that info never came, and I wasn't about to pester a grieving widow. I felt very lost after my therapist passed. I knew he had been having some health issues, but nothing potentially deadly. I felt an immense amount of grief. I had been seeing him for 7 years, and suddenly he was gone. I tried Googling for what to do when your therapist dies and didn't find much. It had never happened to anyone I knew, and I felt very alone. Reading his obituary surprised me. There were so many sides of him I never knew. I did try to find a replacement therapist, but the grief made that difficult. I compared any potential replacement to my original therapist, and they all fell short. How could anyone new be even slightly as useful as someone I've been seeing for 7 years? Someone who knew all my history. No one could measure up. After a receptionist made a slightly snarky comment when I called to schedule an appointment, telling me I should have planned ahead better as they had a 3-month waiting list, I snapped at her, "Sorry, I hadn't planned for my therapist to die." I hung up the phone and gave up on therapy for a while. So, here are a number of things we're going to talk about. How does this affect your family? Are they going to have to be the ones calling your patients? How does that affect your patients when they hear from your family? Is there space for their own grief in leaving you when they feel like, oh, that my grief doesn't matter? That's the family, that poor widow. Where's the space for their experience and their honoring of the relationship with you? Where do they go next? How do they grieve this loss? How do they find a new therapist? How do they reattach to a new therapist, especially if they are feeling abandoned? So we'll talk about all of these pieces as we pull apart why we need to think about our patients and from all the different perspectives we need to think about them. So I am just starting from the point that, or the assumption that we all agree, at least, that therapy is about empathy, support, confidentiality, safety, respect, attachment. No matter what your theoretical orientation and how you practice, I think we can all agree. We start with that. The therapeutic relationship matters. So this is foundational. So when we think about that, what do we owe our clients? The way our work works is by our becoming important to people in whatever individual ways they make us important. We aim to matter. If our aim is to matter, and if we set out to court that condition, what is it for us to be lost? So in a practical sense, you do have to think we court that condition. It is part of our business of therapy, as well as the effectiveness of therapy to create attachments with people. So then what do we owe them? So this is Ellen Pinsky. She is an author who talks about her experience as a therapist, what she thinks, but she also has been a patient and lost her own therapist in a tragic way. So she writes from both sides of the couch. And she points out, if we accept we're mortal, then we're vulnerable, no matter our age. Do we have a responsibility to provide for them? Maybe we don't, but if we do, what is reasonable? And if we think we do have a responsibility and yet we neglect it, why is that? How do we sit with neglecting our duties? She goes on to talk about, of course, the therapist is not to be blamed for the human condition of being sick or dying, but the patient likely experiences that as a tremendous abandonment, a catastrophic breach of the therapeutic contract, she says. Who would begin therapy without the implicit promise of constancy? So let's talk about the ethics code. This is where it's clearer than most of us might remember from when we last took a look. In our general principles, we all know about beneficence, non-maleficence, fidelity, integrity. So I'm not going to get into the weeds on this, but I do want you to see it spelled out that psychologists strive to be aware of the possible effect of their own physical and mental health on their ability to help those with whom they work. That basically means if you are mortal, you have a responsibility to the people who you work with. So here are our enforceable standards. In the interruption of psychological service, we make reasonable efforts to plan for facilitating services. We make plans in advance to facilitate the appropriate transfer and to protect confidentiality of records. And this is key, advance. This is all about proactive planning. I can certainly share with you some of the things that happen when someone is incapacitated or dies suddenly without a plan, and it's not pretty. So this is about making a plan as best as you can, as we can. It also spells out paramount consideration is given to the welfare of the client or the patient. So as we think about what do we need to put in place, we need to think about it from the perspective of how is it going to impact our client, our patient? How can we do the best we can there? So that kind of sums it up. Reasonable efforts to plan, and we're talking really about two responsibilities: facilitating services, transfer of care, and confidentiality of records. Those are the two primary responsibilities we are talking about making a plan for. Okay. So in some states, this next slide looks very different, but from what I can tell, in Arkansas, you are just referred back to APA's ethics code. That is adopted, and that is the most specific. So we'll talk more about record retention and details and requirements in a little while. But this basically tells you everything we just went through, it applies to you. Okay. So I conducted a survey of therapists and asked them, what do you worry about? The things that people worry about, the biggest one is that orange circle. What happens to your patients? How are they notified if something happens to you? That's what people seem to care about the most. 80% of people care about that. How are they notified? People also worry about ensuring the confidentiality of medical records. About 56% worry about that. To whom the patients are transferred, about half worry about that. And then other people worry about how do you get paid for uncollected bills, services rendered? How do you make sure your patients get the paperwork they need for insurance reimbursement? How are your records going to be kept for the up to 10 years, maybe, if you take Medicare, that they need to be kept? What about your lease? What about your office and your belongings? How about how do past patients know where their medical records are? These are the things they worry about. If you worry about something that has not been addressed here, please put it in the chat. I would love to know what else you worry about. So we know what we worry about. We know what we should be paying attention to. How do we do this? So let's talk about what is a professional will. It's a document, and it actually directs your personal representative, your next of kin, the personal estate. It directs them in who and what you want done for your practice. So it's essentially a letter. Dear sweetheart, I know you don't have a clue about my practice, so I want you to contact this other therapist, and here are all the things I want them to do, and here's all the instructions. And by the way, I've given them a copy of this already. That's essentially what the will is. It is not a last will and testament. It doesn't discuss your assets. It doesn't replace a durable power of attorney. It is usually not a legal document. It is a wish list. Here's what I hope someone will do for me. And it's important because if you don't articulate, someone else will decide. But it's important to know that it's not a contract. I can say I appoint Barbie to be my practice executor. That doesn't make it so. Even if a lawyer has reviewed that document for me, it is not a contract. So, a practice executor is a colleague, and I'll come back to this, but depending on your state, and in Arkansas, my understanding is the law says nothing. So technically, it could be your next of kin or your lawyer or your accountant or the person who's going to inherit your stuff who is left with this responsibility. But I want to make really clear, if I leave you with nothing else today, that you understand this is a clinician's job. It needs to be a clinician who is reaching out to your clients and helping them through this. So, a colleague who has agreed to do all the things that you are asking of them. And as we go back to the ethics, it's about reasonable effort to fulfill the responsibilities of those two main responsibilities of facilitating transfer of care and security of medical records. So generally, the powers conferred to the professional executor are really about decisions about your clients and your records, your professional responsibilities. That's what we are talking about. So in that study that I mentioned, of the people who do make a will, why? Why are they most likely to make one if they do? To take care of their patients. That is the reason you care about, probably why most of you are here today. Also, you want to fulfill your ethical obligations. You want to take care of your family and your personal estate. You want to protect your colleagues, but by far, most of you want to take care of your patients. An executor protects, in addition to the patients, the family from having to field calls from patients. So in a minute, I'm going to talk to you about how I interviewed 15 therapists who lost their own therapists in a sudden manner. One of them told me he came back after vacation to a cryptic message from a colleague asking him to call. He was informed that the therapist had died, and the colleague did offer to talk and to help him with referrals. And that's good. That is what we want. That's what we're aiming for. That's a good outcome. The patient felt like there had been a plan. There must have been a plan in place. This was handled orderly. Later, the therapy notes were mailed to him. But then the patient started to get anxious and a bit agitated, and he wanted to know where was the grave. He wanted closure. He kept calling the wife, the therapist's wife, until he could find out where the grave was. So think about, do you want your spouse getting calls from patients when they are grieving you? This patient said he felt really flattened out, were his words, and it took him 6 years before he saw another therapist. So in my study, 69% did not have a will. I actually think it's probably more like 85% don't have a will, maybe even 90. The people who were interested in this subject were responding to my survey, and so probably more likely to have one than in general. And of the ones who do, many of them are probably not really actionable. And we'll talk about what that means, what it needs to be actionable. So they probably don't have the right passwords. They haven't instructed where to find the information that they need. We'll go through what those details are. So why don't more of us do this? Well, denial of our own mortality. It's a big one. Lack of knowledge about what to do, and it's uncomfortable imposing on another person. People often say, I don't know who to ask, who would do this for me. Many people, especially I think in the days of virtual practice, I'm hearing from many clinicians who feel that they don't have colleagues or support to rely on. Oops, sorry, that was not where I wanted to go. Sorry. Oops. That's where I wanted to go. So our culture, Western culture anyway, is deeply embedded in a denial of death. People rarely speak about it. And I would argue within our profession, we have a collective avoidance of recognizing the importance of this. How many of you have said to a colleague, I know I need to have a professional will. I know, me too. And we collude to not do it, to kind of say, yeah, we know this is a hard thing that most of us aren't doing. It's hard to think about. So one of the patients that I interviewed said she knew her therapist was ill. They had scheduled some appointments around her medical treatment. But a few days after the last session, she got an email saying the therapist was going to the hospital for a few days, but she would be home. A week later, the patient got a call from the therapist's husband saying, sorry, I'm mixing up my stories. This person's own husband, sorry, let me get this straight. This person's own husband came home and told her that his therapist had told him to tell his wife that her therapist had died. So, that might be confusing to follow. This patient said either my therapist knew how sick she was and didn't tell me, or she was in denial. Either one is disappointing. And she was angry. at her therapist for not being clear. She said, the therapist continues to live inside of me with love, but with the frustration about how she left me hanging. She would have wanted honesty about the prognosis. She wishes that there had been a plan to let her know when she died. And she wishes she could have been informed about funeral arrangements and attended. Another patient said she had expressed concern to her therapist many times over several months, asking, "Are you ill? Something doesn't seem right." And the therapist denied, denied, denied. One day the patient got a text message from a mutual acquaintance saying, "I'm so sorry." She said, "What for?" "Oh, you haven't heard your therapist died." She was devastated. She went to the funeral, which she said was helpful to her, but she found out that the therapist had been sick for a very long time and had known she was dying and had not told anyone. This patient was later so angry and betrayed. She felt, in her words, that she had been gaslit, just lied to her face. So we don't know. And the point of these stories are not to judge the therapist. People, of course, in their own illness have their own defenses and denial, and we don't know what we would be experiencing and how thoughtful we would be able to be in really difficult, dark moments. But that is the point of thinking about it now. So Corinne Masur is another author who has talked about this topic, and she says that there are a few defenses against the thoughts and feelings of mortality, which interfere with our ability to be our ideal therapist selves. So one, the personal exploration of our inner experience, our own fears, our own imaginings. Without that, we can't be fully in the room with our patients. Are we willing to help the patient facilitate their feelings about mortality, their own and maybe of us? And then the appreciation of that external reality of the need to prepare for what happens to your practice. So denial interferes with all of this. And she says that, like all human beings, we have the desire to quell the inevitable existential anxiety generated by our conscious awareness of mortality, paired with the professional responsibility to maintain this awareness in order to be open to feelings about the subject and those of our patient. At the same time, we have the normal human desire to live life in the most comfortable fashion possible. Sorry, I think I see people writing, and I should have said earlier on or that Kyla and Judd have the slides, and we'll email them to you, and you may have a copy of everything. Sorry.
Yes, thank you, Dr. Miller. I did put those slides in the chat as
Okay.
well, and I'll put them in there again. Thank you.
All right. Thank you. Just want to make sure nobody is needlessly scribbling away. So she also says it's interesting that we who pay such close attention to the smallest details of content and nuance of our patients' inner lives would neglect such obvious and important aspects of their care. There are some cultural differences, perhaps. Akhtar has written that there's greater denial in Judeo-Christian cultures that sanction denial of mortality, and that his opinion is Muslim, Hindu, and Buddhist traditions, death is not kept so far from personal awareness. He also says death is the greatest narcissistic injury. We don't want to think about not existing, so we don't. So Nancy McWilliams talks about this dilemma that Corinne Masur was referencing. On one hand, our ego ideal is to think we can handle all disturbing human experience. And so the fact that most of us don't do this is an expression of our avoidance, our defenses. She says, periodically, we all hear from APA that we should have a professional will. A very good idea, I always find myself thinking as I keep transferring that task from one to-do list to another. And so relatable. We get it. We all get it. In interviews with elderly analysts, most emphasize to me that they don't need to worry about it yet, that they're healthy and they exercise. And I am not here to say that one age is more likely than the other. My message is we all need to face the possibility. There has been some research that bereaved clients who noticed a change in their analyst and whose questions had been answered honestly did better after the loss. And patients whose analysts failed to address their health issues had difficulty trusting another therapist and experienced more self-blame. Those who did best had an intermediary person who notified them and offered support. Another author, Ruth Garfield, is a therapist who wrote about her own medical diagnosis, and she said that she believes patients have the right to know based on a relational model of working. She said she didn't think she could hide her own fear and sadness. She knew that they would see it, and she believed in the importance of being honest and authentic. She said most patients tolerated their grief and worry, and they offered good wishes to her. She said 2 patients did not return after she told them how ill she was. And she said, I think it demonstrates something about my state of mind that I did not anticipate these reactions, despite knowing these patients well and trying to focus on taking care of their needs. So we have a big blind spot here in terms of what would happen if we weren't here. So we will pause for a moment, and I am happy to answer questions really just on this part. I know you guys are going to have some questions about how do you make a will, how do you put it in the will, what those kinds of questions. I'm going to get to it, I promise. And let me, I guess, give you a preview of what's coming up. The next section is going to be about the responsibility well, first about the impact on clients, and then about the responsibility as a practice executor, what we need to do for someone else. And I will share my own experience in some detail, because I think you need to understand that before you can get to what are your wishes? What are you going to ask someone to do for you? And to really be able to understand that fully. So we will get there. I think that's probably why you're here today. That's the part you're most eager to hear, maybe. We will get there. But for now, if you're if you want to unmute yourself and ask a question, you are welcome to do that. Otherwise, I think Kyla is going to read some questions from the chat
Yes.
for me.
Yes, I will, Dr. Miller. Thank you. We had a couple of comments and then a question. So when you had the slide earlier and you wondered, are there anything that other people think about? So Dr. DeRay put in the chat that as she works in the legal field, she also worries about attorneys and judges being aware, especially since she's court appointed.
Mm.
So That's another aspect of her concern. I put that in addition to who the patients would be referred to, I would also worry about like would they actually go to this person, and you kind of address that, but would they go to that person and how might that impact their prognosis and course of their symptoms? And then a question was, did your research also cover sudden death? This person said that their colleague died suddenly when she was in her early 50s.
Yeah. So my research did cover any circumstance where the therapist died suddenly. And so yes, many of them had an accident or were going in for a knee surgery, but had a complication and died, fully expecting I'll be out for 6 weeks. I'll see you when I get back. These were sudden circumstances. The examples I've given so far maybe are about how they noticed. That's helpful for me to think about and maybe change it up a little at the beginning, because certainly no, it's not all about circumstances where people were warned. Yeah, it's really terrible. Anybody want to unmute and ask anything? Oh, here's one.
Yeah, so thank you, Dr. Root. She said she's curious how spouses would be able to contact clients to inform them of a death when the contact information should be stored in a way that no one else can access it.
Good point. Yes, yes, there are all kinds of problems inherent here. Things should be secured so that no one else should be able to have custody. More often than not, it is the family that's going to figure out how to get into the computer or find the key for the file cabinet. And in the absence of a colleague who's been designated to help, it is often the family who is just trying to do the right thing, trying, like imagining, oh gosh, I know he wouldn't want his poor patients to be, left hanging. I guess I'll call them. It's with lesser of evils. But good question. They shouldn't really have that contact information. And it is an important part maybe of how you think about who can help you with this and how would they have access. And we're going to talk about access and in a lot of depth.
Thank you. And I think Dr. DeRay may have had a question. And then we have one more in the chat after that. Dr.
Yeah,
DeRay?
I just had a comment on this about having a colleague that just recently passed away and his spouse having to take care of everything. I was trying to help her and trying to get into a computer file that we could not get into, and helping her like go through files and what can we destroy now that are over the limit of time you have to keep them. And there was also legal implications since we both worked in the legal field. So yeah, these are all good questions and good points.
Thank you. Yes. I think we come to this through experience, most of the time, to appreciating what is entailed.
Mm-hmm.
Um,
Okay, there's a couple other comments, it seems, if you want me to read those, Dr. Miller.
yeah.
Dr. Hicks says, at this point, I can imagine it would be difficult for a therapist to help a client process their own impending death. Is there a way to give the client extra support while the therapist continues to process it, especially if it is a sudden diagnosis and illness?
Yes, absolutely. Good point. It can be too complicated, too overwhelming, to process. And in the example of my friend, she had a little bit of time to tell me what to do, and I'll talk about that. But she wasn't able to sit with her clients and process her impending death. And so part of your plan is what happens to them. Are you able to think of good referrals where they can go and process what they need? Do you have an idea of who would be a good match? And do you want to facilitate that or ask your professional, your practice executor to facilitate that? to help the client get the additional support that they need. Um, it is a painful experience, and a number of the people that I spoke with yesterday, some start off by saying like, I saw him for so long, nobody else would be able to understand. I don't want to see anyone else. And after I listened a bit and sat with them a bit, and I kind of said, nobody's going to replace him to you, but to be able to process this loss of this really important relationship that you have had with him, and also to continue to support you in the other stressors in your life. Um, will you consider, seeing someone? And um, one person cried and said, "Hey, I really can't talk about this. I'll call you. I'll talk to you another time," which I totally understand. And other people are kind of like, "Yeah, yeah, get me those names. It'll be good just to have them for when I'm ready." Um, the best we can do.
Right. Okay, thank you for that, Dr. Miller. These are tough, heavy topics, heavy topics. Thank you for addressing that. Dr. Rutherford said that it's a form she was thinking of, seemed like in the next comment, it is an insurance form that she had to fill out for her secretary so that she could know the information about her clients. Wouldn't that person be considered in that role, perhaps along with a clinician?
I think you may be talking about a BAA, a business associates agreement.
Okay.
Yes. Okay.
Yes.
Okay. Yes, it is really important to be able to have that kind of smooths over any HIPAA compliance issues. It ensures that, that person is really acting as an agent of your practice. And so the information that you would know, they may know, and they will honor it in the same way according to your responsibilities. So that is a good thing to consider having, and that is part of the professional will that we build, so it has that attached. Okay. All right. Well, let's move forward then, if nobody has any other questions. And we are going to take a break. I'm looking at my slides. I think I might have put that break in the wrong place. So maybe we'll figure out together, maybe at about halfway, we'll take a 10-minute break. Okay. So a huge part of this effort is about helping people understand the impact of inadequate planning. And again, there was this New York Times article in the summer, which I was very happy to be a part of, as we're really trying to let people think about this and sit with our responsibilities. So here are some additional quotes of people who wrote into that article, commenting on the Times about their therapist. "He didn't show for an appointment. He wouldn't respond to my calls or messages. This was after I had to cancel an appointment, and I thought he was dropping me as a client in a hurtful and unprofessional way. I tried to reach out again to get a definitive answer, and that's when I found his obituary via Google." So it's important to remember that in the absence of information, like children, maybe your clients are going to think it's about them. They did something wrong. You don't want to return their call. You don't want to see them. That feeling of rejection and abandonment is a pretty common one when they aren't given any way to understand what's happened. Someone else, "One day I simply walked into her office for our usual appointment and no one was there. A few weeks later, I saw her obituary. I went to her funeral, but seeing her traumatized family only made me feel more disoriented and sad. Seeking out a new, unfamiliar therapist to process this felt unthinkable." So again, there are many barriers, some emotional, and many are practical, depending on the population that you work with. It can be really difficult for people to find out where to go that has availability to see them and takes their insurance, and all the barriers that might have people give up and not end their treatment and not continue with their care. Okay, so the 15 therapists who suddenly lost their therapist. There was a very positive treatment. And after summer vacation, the patient got a call from the therapist's colleague saying that she had received a terrible diagnosis and said, if you'd like to reach out to a covering psychologist, you can call. The patient called to ask, would the therapist be seeing patients again? The therapist's husband called to say no. Very soon after, the therapist's daughter called to say that she had died. The patient had a history of early loss. She felt really angry about how this was handled and described feeling that she was so enraged she was almost unable to be sad. Another person lost two therapists. One, in a wonderful therapy, the therapist had said that she was terminally ill and needed to end the treatment, and she invited the patient for one goodbye session. That made all the difference. Of course, it's not always possible, but if possible, that can make a huge difference. The patient said she was so sad for the therapist and for herself, but she felt cared for and loved and was grateful to have been able to say thank you and goodbye. That was huge. When her second therapist, many years later, got sick, she got a call from a colleague canceling the session because he was in the hospital. The patient called the hospital every day in the days when you could do that, and wanting to know how he was doing, and he recovered. Later, she received a letter saying that due to doctor's orders, he needed to end the treatment, but she knew that some other people were still continuing in treatment with the same therapist. He had just fired her. She felt very rejected. This was really painful. He did die soon after, and she began to receive bills from his wife for sessions she had already paid for, adding insult to injury. So this patient said, in the first case, it was so reassuring that I felt cared for. And in the next, she said, what I was worried about most wasn't death, but rejection. And that is what she was left with, feeling rejected. So of these 15, two found out by text. Two received a call from the spouse. This is what we're looking for. Three out of 15 were told by a colleague of the therapist in a sensitive manner. One was told, I have no one to recommend you to, by the therapist who was calling. Only one of 15 was given referrals. One got a phone call from an administrator who the patient thought seemed overwhelmed and never followed up. 5 felt rage. We're going to come back to this a little bit later, the rage, and how we are trying to mitigate that in the role of practice executor. So we'll come back to that. Only one in the 15 knew what happened to his medical records. And take a guess, how many of the 15 have made their own professional will, even having been through this? 6. So Ellen Pinsky, who we heard about earlier as the therapist, is now talking about it as the patient who lost her therapist. So my grief was amplified by confusion and isolation and complicated by a sense of absurdity. No one close to me knew this person who I felt so close to and spoke to so freely and privately. What is it to lose someone who attends the way the therapist does? Who was this person to me? Who was I to him? That question seems to be at the root of what patients feel. Did I matter? How did I matter? Did he care about me? Did she care about me? She went on to say the loss of my therapist had to be mourned, but whom had I lost? What had I lost? To take its measure, I also had to wonder what had I been given? She said, the man mattered. He died and I had to grieve. But how was I to do that? What form would it take? She says, maybe something ordinary. I'd go to his funeral. But on whose invitation? Who would I sit with? Who would I talk to? Would I sign a book? Who were his friends and family to me? Who was I to them? She says, in the shadows, always. Who was I to him? So the risks to our patients, I've been over a number of these already, but emotional instability. They find out in a really sudden, painful way. They are left waiting and never informed. There's unprocessed grief that they have to sit with. They feel abandoned or rejected. They may really be quite destabilized or regressed. You have to think about who are your patients. Think about what population you treat. Think about their history with trauma, with loss. Think about their history with rejection and abandonment. They're going to react how they react to those experiences with others in their lives. So we need to think about, especially with, let's say, a population at risk, what the loss of the therapist might feel like and mean to them. There's also harm to the public. How, you might wonder? Well, there is the potential for violation of confidentiality, as was asked in that question. How does the spouse get access? Patients might really resent that the spouse had access to their information and is contacting them. It's on a broader scale too. When you don't control what happens, you really do not know what will happen. And so even in the most well-meaning situations, things happen that you would be horrified by. For example, a state psych association told me about a complaint that the board had received about a therapist who had died because his spouse had put the paper records on the curb in the recycle bin, and a big storm came, blew them all around the community, and people were picking up psychotherapy notes from their yards. So well-meaning, but other people don't have our professional responsibilities. They don't know what they are. They don't know how to comply with them. And for those of you who have 30 years worth of records in your basement or in your garage, and I know some of you do, I hear this all the time, please consider getting rid of them, the ones outside the retention period, so that your family or your colleague isn't buried in boxes and boxes and boxes of paper that they need to figure out what to do with. So examples like that can fuel distrust of the profession. So can the comments that I read to you of people's experiences, if they feel like my therapist just didn't ever call me back, I don't know why. and they go telling that story to people. Geez, your therapist just dissed you, without knowing the circumstance. It really is not a good look for the profession. There is the financial impact of reimbursement issues on both on your clients and on your family. If you have not had time to bill or submit for all the services you've provided, who's going to do that? Because your family is going to be suffering from loss of income. On the patient side, especially if you see people out of network, pay for fee for service, those folks need their super bills to get reimbursed. And if you don't have a way to provide them, then they're just going to be out that money, which maybe they can't afford to be out. And as I mentioned, there's disruption to access of care. To reinforce the family piece here, someone had written in, my partner was a therapist and died suddenly. I was put in the position of deciding how to handle her death in relation to the clients. She handled scheduling all her appointments herself, so I was left answering phone calls, emails, and letters from clients. I was quite uncomfortable about this activity as it violated confidentiality. I did not want to know who the clients were, and I'm sure they didn't want me to know either. But I could hardly leave everyone in limbo. Of course, I did not have the knowledge base to refer them to other therapists for follow-up. Someone else said that the wife called. So remember, your family, if they're put in this position, would also be grieving and going through their own shock and overwhelm. So this patient said that his wife's therapist called out of the blue. She didn't know he had been sick, to tell her that he died. This person said, I responded in shock, he's dead? The wife, a therapist herself, responded curtly, what part of dead don't you understand? She said, I especially missed my therapist at that moment to tell him what an insensitive idiot he had for a wife. That is, just to say we are not going to be at our best if we are having to make these calls on behalf of a loved one. So you don't want them to be in that position. Okay, so either you are asked to step in and help if something has happened to someone else, or as you're thinking about what would this person have to do for me? How do I tell them what to do? It's important to think through each of these steps. So these are some guidelines about what has to happen when a therapist is absent. The first phase is all about current patients or clients. How are they notified? What do they need? How are they provided with referrals? How are they supported? The next might be about the business of practice. And lastly, then we get to some of the administrative pieces of dismantling a practice. So I'm going to say here a little bit, I think, first about the circumstances, because most of this comes from the first experience that I had doing this. So my friend, who I will call Dr. B, was seemingly healthy and young. And one day I got a call between patients from her saying, I'm in the hospital. They found a tumor. Can you take my practice? And she died 6 weeks later and never set foot in her office again. So obviously this was a devastating situation for her family. Certainly was for me, and then for her patients. So because I did have very limited access to her for a short period of time, I was able to get instructions from her, which usually we're not privy to when someone simply dies and we can get no further information from them, what they want us to do, who the clients are. But I was able to have some of that insight. And I think it created a situation that was aspirational. It was almost like the best way this could be done because the therapist is sitting there telling me what I should do with her deep compassion and caring for her clients. So there weren't really, shortcuts or excuses to make. I don't know what to do. I don't know what they need. I knew because she was there telling me. And so a lot of these guidelines that have come with the idea of like, if you could whisper to someone, if you weren't there anymore and you could whisper to someone, here's what I would want you to do to give the best possible care to the people who matter to me. What would you say? Here's your opportunity now to think about it that way. So what we figured out that needed to happen. The first thing, okay, where are the medical records? Are they locked away? They're safe, they're secure. Okay, I don't need to think about that right now. Next is, how are people going to continue to be calling the therapist to schedule appointments, to ask questions? We want to stop that. We don't want more and more voicemails coming in. We don't want people trying to reschedule. So changing the voicemail to say something like, the practice of Dr. B has been closed, or initially in this case, Dr. B is on a medical leave of absence. For any questions or information or access to your records, please contact the practice executor. Okay, so you become the point person for anyone looking for her. Then you want to get as quickly as possible that client list. Who is currently being seen and how do I get a hold of them? And where's the calendar? Because in this circumstance, I still had my full-time private practice, 2 young children, and now I needed to call her full-time practice worth of patients, 30 plus patients. And these are lengthy calls. So you want to know who's coming up. Who do I need to call tonight because their appointments are tomorrow because I can't call all 30 people tonight. How are you going to break this down to do it as responsibly as possible? Before you call, you want to know, all right, if this person is in crisis, where am I going to send them? You want to have some available crisis intervention referral. And let me be explicit, you as the practice executor do not need to take on these people as your own clients. You don't have to treat them or see them for therapy. You can if you want to, but your job is to facilitate that. So you would want to have some, at least crisis referrals on hand if necessary. And then you may take some time to think about or to work on finding longer term referrals for folks. You don't have to be, coming prepared for that. What I had done at that time was I called, 5 close colleagues and kind of said, could you be available to cover, let's say, 3 of Dr. B's patients? Can I give your name to 3 people just in case they need help before I'm able to get back to them with a referral? And that worked out to sort of spread out that way. So then you're going to make those calls, which I will talk about in more detail. If you have a group practice, if you do testing, if you have supervisees, whatever your other professional responsibilities are, you need to have a plan for that as well. So a group practice owner, it might be in the plan, contact my the director, contact my admin person, contact the supervisor of my unlicensed clinicians, contact this person, let them know, let them tell the other people. This person may, need the information for how to facilitate payroll or pay the rent so that everybody doesn't have to stop seeing their patients in the same moment. But the practice can kind of hobble along a little bit until your estate determines what happens next with the practice. So think about it from every detail. Dr. B was very, I think, unusually compassionate and devoted to what her clients would need. And she gave those instructions to me. So she said, call this one who's a college student only on the weekend when they're home with their family, because then they'll have support around them. This guy is paranoid, so call his father and tell his father to then go and tell him instead of you calling him as a stranger on the phone. With a lower functioning person, ask for a joint call with her partner and tell them both at the same time on the phone. There was one client who was newly pregnant who had recently miscarried, and Dr. B was extremely concerned that this news would trigger another miscarriage. So she wanted to keep on seeing this client kind of on phone. This was pre-pandemic, but by phone. And it was clear she could not do that. She had no capacity. But what we worked out was that I would tell the patient the truth, but only little bits of the truth over time until she got into her second trimester. So I told her initially, she's sick. We have to cancel your upcoming appointment. I will call you back, or she will call you back. Then I called back a week or two later. She is in the hospital. They're trying to work things out, let you know more. Then again and again until we could tell her. And 6 months later, she sent me a birth announcement saying she wished that she could send it to Dr. B. But these, connections with your colleagues' clients actually are quite powerful as you kind of step in as a transitional object for them, really trying to kind of hold the relationship. So what are you doing as you are thinking, I'm going to make phone calls to patients I don't know for someone else, and these are essentially termination calls that you're making. So how do you do that? I kind of thought about the goal, and this goes back to what I was talking about earlier with the anger as the reaction to feeling abandoned or rejected. I think the goal is to try to help that patient preserve the good of the therapy that they had. They are going to experience loss, no question. We can't prevent loss, but we can prevent what we're trying to prevent is traumatic loss. So being able to communicate that you are calling on behalf of the therapist who deeply cared for them, however you're going to communicate that, is part of the goal. So gonna be authentic and be mindful of what the issues are that the clients might be dealing with that may be triggered by you calling with this news. abandonment, loss, trust issues, feelings of rejection, and so forth. Existential anxiety. Oh God, if something happened to her, could that happen to me? Empathy, the desire to help. People are so caring. Most people, most of the times. Can I bring a casserole to her family? Oh my gosh, can I make a donation? Can I, and to be able to have to tolerate, they have to tolerate. That's so very kind of you. I know that her family would appreciate it, but no, thank you. And that's frustrating for people. They want to be helpful. They want to express their caring. So being mindful of all of that and of your own, grandiosity, coming to the rescue, your own depressive stance, whatever it might be. These are really, really hard calls to make. And I would make them in the evening and, put my head down and cry after I would hang up these calls for, my friend who I was, deeply mourning myself. So I consider these termination by proxy. These are not quick calls. These are not calls you make in the 10 minutes between your patients. These take time. If necessary, leave a message saying, as I did yesterday to a number of people, I am the psychologist covering for Dr. B's practice. It's important that you call me back, and leave only that in the message. And what I put together to kind of say over time was something like, I'm the psychologist covering for Dr. B's practice. Are you in a quiet place where you can speak privately? Are there supports available to you? I have upsetting news to share with you. Dr. B wishes she could tell you herself, but she's not able. She has been diagnosed with. And Dr. B wanted me to say to every patient that she was diagnosed with terminal pancreatic cancer. That was really important to her to say it so that they didn't have false hope that she would return. And if you don't articulate what you want and what you don't want, someone else is going to guess for you. So if you would want things shared, write it down. If you would not want information shared, write that down. So she's very ill and is not able to be available for her patients anymore. And then silence. And that is where you create the space for people, not as their therapist, but really as a human to human interaction with someone who you've just, told this news to, and you're going to sit with them and allow for their reactions. And, what all you might say sometimes is, those empathic murmurings. I know, yes. Therapy, a relationship is really very deep and meaningful. This is a tremendous loss for you. I'm so sorry for your loss. And like someone said to me yesterday, no, it's about the family. It's about his family. I'm so sorry for his family. It's not about me. I'm saying, well, I appreciate that, but you've had a long relationship with him, and this is painful for you too. If you say you're going to call back, do it. Keep your word. Keep meticulous notes so that you are following through in the way that you promise. If it's clinically indicated, you might want to consider an in-person meeting. A lot of people ask, if there's an incapacitation, can you call me if they die? I want to know when they pass. I want to know if there's a service. Can I go to the service? So these are important things to think about for yourself too. What do you want said when a patient asks that about you? Would you want to allow them to attend a service? How much information can your executor provide? So you're going to document everything. some of the reactions that I got from calling Dr. B's patients, most were along the lines of, I'm so grateful. Please tell her she has been a wonderfully positive force in my life. I'm shocked. Dr. B was amazingly stabilizing for me. I could always count on coming in and getting grounded. Someone else who was a chronic pain patient was so concerned with Dr. B's pain level, and wanted me to wanted to give me marijuana to give to her for her pain, which I had to decline. But people want to help. So this person had said, Dr. B had been there for me more than anyone ever was when I was a kid. She taught me emotions. Literally, she taught me the words. Someone else said, tell her I'm okay. I don't want her to worry about me. And then 2 hours later showed up at my office with a letter that he wanted me to give to her, fearful that she would die before he could tell her what she had meant to him. One person, again, as I cautioned to remember who your clients are, someone said, I am so hurt. I will never seek another therapist. What a waste of a decade spilling my guts only to be screwed over by the one person I trusted. I see the smiles. It's diagnostic, but again, remember, the way people respond is the way people are going to respond. So, as you can tell from what I've said, these are really, really hard. There's this impact on the executor. And so I do, from this experience, warn against having someone that you're close to do this. It's really, really hard. It's an honor. I certainly want to communicate that I got to do this, and it was really helpful for me in some ways to be able to help rather than have that powerlessness. But it was really a tremendous job and quite overwhelming and painful. And I definitely felt like there wasn't space for my personal grief in mourning the loss of my friend. So those are all things, that your executor might experience. And it's also important to think about, it's a parallel process. Your executor is going through the shock and grief and uncertainty that the patients are. And it's difficult to be in both shoes at the same time. So I think we should pause there and take about a 10-minute break.
So
And
Dr. Miller, there are a couple of questions in the chat that are kind of relevant to kind of the phase one that
okay,
I wanted to bring to your attention.
that's
The
fine.
first one,
Sure.
yeah. The first one is, would it be appropriate to have a letter prepared in advance for clients as a component of the will?
Absolutely. That is an option that we provide people. Some people love that idea. Some people hate it. There's no right answer, whatever speaks to you. But yes, you absolutely can write a letter, usually along the lines of, if you are receiving this, it means that something unexpected has happened, and I want to share with you what an honor it has been to do this work, and whatever you want to say. I wish you well, variations on that.
Very good.
Yeah.
And the second question is, how have you handled sharing with child clients? Is it only to the child's guardian or both? Or if older adolescent, tell them privately?
To the parent, because I am a stranger to the adolescent, even if they're an older adolescent. Um, there may be circumstances where it would have been better maybe if I called the older adolescent, but not knowing, I think most of the time I'm going to go with the idea that it's probably better coming from the parent than from me. But I do communicate that I am available. The practice executor is available to assist with referrals, to answer questions, and to facilitate the transfer of records. So I would direct the parents to inform the adolescent that they could reach out to me if they wanted to.
Good. This next question is more forward-looking into what's coming up after the break. The question is from Dr. Griffin asking, are you planning to cover the steps for closing a practice?
Yes, I will. And I think we skipped one. I'm gonna go back just up above a colleague suicide without planning, and a lot to do to try to take care of patients and files. So thank you. You know too what mess is created and left for those who want to provide support and help, but how hard it is. I have heard from many therapists that, somebody in their suite died and everybody else came together to try to go through the files and figure out what to do and how overwhelming a job that is. I have heard from a therapist who is also a landlord and requires that her therapist tenants have a professional will because she doesn't want to get stuck with the responsibility of dealing with their records if something were to happen to them and they're her tenants. So take a pause there for 10 minutes. We'll come back at 3:40.
Okay, and that would be 2:40 our time. I know you're on Eastern time, but that'll be 2:40 Central Standard Time. Yes, you are. Okay, thank you, Dr. Miller. We'll be back at 2:40 Central Time. Thank you.
Got it.
Looks like it's 2:40, and I'll just let you pick up when you're ready, Dr. Miller.
Okay. Give everybody one more minute. Okay. All right. I'm caffeinating myself for the second half. Hope you are too. So the second phase of the executor role, once the current clients have been notified, you've called them back to tell them about the memorial service, you've called them back with a couple of available referrals. So these are, multiple conversations probably that you're going to have with them. But once all of that is done, then you can think about what are the financial components of the practice. And so a decision to make is, should your practice executor handle that, or is that the personal executor? It's often not talked about. And so it would often fall to the personal executor to handle the bank account and the credit card and so forth. But what's not considered is the breach in confidentiality if they are the ones to facilitate any statements or payment, seeking payment on behalf of the practice. So again, these situations do happen, and sometimes it's the best we can do, but with good planning, it's certainly not ideal to leave it that way. The practice executor, on the other hand, may have more information even of how your practice runs and how they run theirs, and be able to understand how to bill for sessions that have been completed and how to issue a super bill. And so you really need to think that through. Who and are they willing to take it on? Dr. B was very much relying on me to do so, and so I did, but I had not considered it ahead of time. It hadn't occurred to me. And it actually was a tremendous amount of work to go through someone else's whole system and issue bills and then have them, um, this was again pre-pandemic. So our most things were on paper and they were sending in paper checks that my friend's husband was kind of like, whatever you can do to help, we will take. So I was going to her bank and depositing her checks in her account, again, above and beyond what most situations will require, and part of the cautionary tale around leaving it for a close friend. So these are the things they might do for you. So I still now, as an executor, I don't handle anyone's bank account or credit card. I can facilitate payment like through an EHR system where it's already set up and I can click pay and I can, click submit. But the money, the assets are family domain. And again, there are certain other responsibilities like terminating your lease or dissolving an LLC that would require more legal authority than I have. So you may want to consider a limited power of attorney, setting that up if that is something that you want your practice executor to be able to handle for you. So the third phase is the closing of the practice, and this does apply to retirement as well. All the things that I'm going to say here do apply just the same. The difference being that in retirement, you yourself are telling your clients that you're retiring, and you yourself are helping them by facilitating transfer and referrals. And you are then making the plan for what's going to happen to the records. So, but then the next steps are quite alike. So the first thing you really need to do is figure out the state-specific requirements, both regarding retention and the requirements regarding notification of past clients about where their records are being transferred to. So most states have laws saying that client has the right to access of their records. So that's interpreted usually to mean they need to know where they are so that if they want them, they can go get them. So from what I can tell, and correct me if I'm wrong, anybody, please, but there is only a requirement for hospitals to retain records for 10 years and for 2 years over 18 for a minor, but there's no explicit requirements outlined in the law for private practice. I'm not seeing any nods. If you believe this is true, nod. Nobody. Crickets. Okay.
We did have a note in the chat. Dr. DeRay, who's the chair of our ethics and professional practice, said that we did have a peer consultation about it, and I am trying to remember the exact thing. I think we did look at it, and
so I'll carry on. You see if this rings a bell.
I'll pull it up.
All right.
Okay.
Thanks, Dawn.
So what I can tell is that, again, there's no notification requirement either. And what I hope you're going to confirm is that because, as I showed you before, you're referred back to APA, the APA suggestion is 7 years. So the minimum then would be suggested to be 7 years retention, except if you take Medicare managed care plans, which are 10 years. So you follow the most conservative. HIPAA would say 6 years, but APA says 7. So without state guidance, my understanding is that if you're in private practice, go with the APA 7 years unless you take Medicare. I do see a nod now. Thank you. Thumbs up. Okay. These things are so difficult to research and determine. Hey, your therapist from 5 years ago died and somebody else has your records now. You can see how this is sometimes clinically contraindicated. You don't, why out of the blue would that be good for a patient to have that happen? Probably not. But what are your legal obligations and how does that interact with what you think is best clinically? There are also some states that do say you must have a plan for your records, explicitly written out, must have a closure plan. In Oregon, they are the strictest. They say you must have a qualified person, who must be, if you're a licensed psychologist in Oregon, you must name another Oregon licensed psychologist as the person who takes responsibility for your records, and you must submit that for your licensure renewal. So that's that degree of supervision is not there for most states, but I think it's worth considering because this is something we don't want to do unless we are made to do it. And again, whether you have to have, whether the qualifications for a practice executor exist or not differs, whether you have to report it to the state differs. So you really want to be thorough in looking at where your responsibilities lie. So the other elements of closing the practice, in addition to determining who's going to keep your records, how long do they need to keep them, where are they going to keep them? If you have paper files, does the person you are asking to keep them have space for them? And will they be locked and secured? And then what happens if something happens to that person? What happens to your records? If they're electronic, how are they going to get access? And we'll talk more again about that in a minute, but are they going to maintain your EHR for the foreseeable 7 to 10 years? Is your estate going to pay for that? Does your EHR have the ability for an executor to download all the records and securely store them themselves and then close the EHR? Some do, some don't. Some only have storage plans because you can't get your records out except one at a time if you needed to give that record to a patient, but you can't get all the therapist's records. So you have to pay a storage maintenance plan for that duration. And I've actually reached out to my own EHR where I've discovered you cannot download records, and it's a big problem, and trying to talk with them to help them understand why that's a problem for an executor not to be able to get records. So anyway, that once you've solved for your records, the other things you need to think about. The executor is still going to get calls. So if you are retired, you're still going to get calls. You're going to get people who are looking for you, who didn't know that you were retired. In this case, people who didn't know that Dr. B had died. People who are looking for referrals, a lawsuit, that somebody wanted the records for, subpoena, all kinds of things continue on. We recommend that phones and websites stay up for at least 1 year. The 1 year is a bit randomly chosen because it's practical and there are no absolutely clear guidelines on this, but um, one ethicist that I talked to said, well, why are you saying 1 year? It should be like 7 years in Maryland. And again, that's not in the law. That's kind of thinking about, well, how do people know for that duration how to get in touch with you? So that's part of the responsibility. How would people find out 6 or 7 years down the road who has their records? We advise 1 year, in which people would be met with a message saying this practice has been closed and anyone looking for information or records should contact so and so. And part of the notification, like in Maryland where I am, it is required that we notify all past patients in the 7 year retention period where their records have been transferred to. So in Maryland, my executor must send a letter to all of the people I've seen um, whose records are being retained, saying that they don't have to announce that I have died, but they do have to say the records from the practice of Dr. Robyn Miller are now located at, and if you should need them, here is how you seek them out. So the ethicist that I was referring to is a Maryland-based person, and to his point, like the 7 years, people are informed because they've all been informed directly. So you don't have to keep your phone and your website up because they've actually been told directly where their records can be found. What about social media accounts that have to be closed? What about auto payments, things that are just routinely charged to your credit card, your Psychology Today, your Zoom, certainly your malpractice insurance, which needs to be notified. And if I think that's on here too, if you need a tail policy added, I think the trust adds one automatically when they are notified that you've passed if you use the trust, but others may need to purchase a tail for that policy. You want to notify the licensing board. Often it's helpful to tell the licensing board where the records will be held. So if somebody can't find you, they call the licensing board. I don't know what happened to my therapist, but I need my records. They will be able to say, okay, this person has your records now. This one is an anecdotal one that probably doesn't happen that much. And I just looked up and realized, even though I've been plugged in this entire time, for some reason my computer's not charging. Okay, that looks better. This is about really thinking through all the pieces of your work and your practice. So Dr. B, I went to her office. I had to take her physical paper records because that's all we had then, and load them into my car and looked around and thought, do I have responsibility for anything else in here? Her family was going to come and pack up the office eventually. And I saw all these little pieces of art or arts and crafts that were on the bookshelves, that were, different places around the room. And I just knew that they were patient gifts over time. And some had little writing in the back. And, so I didn't know what to do with them. And I kind of thought, well, if I leave them here or if I throw them away, like neither one feels right. So I'm going to take them. And I took them and stored them with the records. And about 6 months later, I got a call from a former patient who had terminated a while back, saying she just found out that Dr. B had died and she wanted to know what happened to all the objects that she had gifted Dr. B over the years. And I was able to tell her that I had them and I could send them back to her. And she said I had given them to her in hopes that she would hold on to me, but now I'd like to have them back so I can hold on to her. And, these were again, another sort of, I still feel the emotion of that encounter. So just think about all the things that you might want. Do you want to help the family with packing records outside the retention period, destroy them? It is recommended that you keep a log of the records that are destroyed. So if someone comes back to you, you can say, I'm sorry, I shredded your records on X date because they were outside of the retention period required by law. Just trying to find a little bit of humor here. None of us want to talk about it. Okay. So now the two pieces remaining are, what do you want your will to be, and who can do this for you? So hopefully you've been thinking, as you've heard some of these stories, thinking about what you want. And I encourage you, jot down some notes if it's in your mind now, any of the particulars that I've talked about, if that makes you think like, oh yeah, I want that, or no way, I wouldn't want that, write it down. Okay, so what do you want? Deriving from the conversation or the stories told, I want to think about how should they be notified. I think by phone is better than by text message or by email or by a notice on the door, which is what often happens if nobody can get access to the client contact information and there's a physical office. This is less and less an option now as people have mostly telehealth. But what used to happen is somebody puts a note on the door saying, patients of Dr. Miller, please call X. And that's where then you call to be told then actually your therapist has died or whatever the situation is. So short of, leaving it to that, what do you want? What are your personal boundaries around how much information should be shared with your clients? Often, I, myself included, I'm pretty reserved as a therapist in the room as far as disclosure goes. But you also want, and so some people say, like, well, I don't share very much, so I wouldn't want them to know much, which is fine. That's your right. But I would ask you to think about, when most people accept what you tell them. So I tell people a minimum amount of information. It was an accident. It was a medical issue, and many people leave it at that. The ones who push further do so typically out of anxiety. The unknown is so much worse than knowing, and so many therapists that I work with say, if they really want to know, tell them like it is. Tell them what happened if that's going to help them hold it. But think about what you want. Do you want to write that goodbye letter that we talked about earlier? Do you want to make a list of people you like to refer to so that the executor can call them and say, hey, do you have any openings? Do you think you could take on some of Dr. B's clients? Do you want to offer in-person sessions? Does your estate cover the cost of that? Sometimes people choose that your estate would pay the clinician's hourly rate to have everyone come in once. Again, what are the expectations about the records? How are those financial pieces going to be handled of the practice? Compensation for the executor is a important one to think about. In the days where professional wills were, you know, I don't know, scratch that. I don't know how to end that sentence. Dr. B and I did it because we were very good citizens and thought when we started our private practice, like we are told we have to do this, so we should do it. And it was the old, somewhat informal model, even though we did name one another. But it was the idea of, oh, I'll do it for you if you do it for me. Sure. And as you can tell, there's a fallacy there. Only one person will have it done for them, not both. You will not do it for each other. So that's one thing to just note. But we also did not, think about compensation. But now I am hearing more and more that people are realizing what a huge amount of work it is. And so people are really worried about who do you ask to do this for you, who could handle this burden, who would have time. And people are often writing now into their wills, my estate will pay you your hourly rate for time spent serving as practice executor. That is a way to do it, but it's important to think about, now that you've heard all that's involved, that makes a lot of sense if we think it takes 2 or 3 or 4 hours worth of work to do this. But I think it takes 2 hours per current client. So if you see 20 active clients, it's going to take someone 40 hours to do all of this work. And then your state, depending on that person's hourly rate, is going to owe them $10,000, $20,000. That would be a big surprise. So another way, some people are saying they put aside that money just in case it's needed now. Other people come up with an agreement of a flat fee, that my estate will pay you this flat fee if necessary. Others come up with we will make a donation to the charity of your choice. There are lots of different ways, but again, it's important to think about what you would want and have that conversation with the person who's going to serve for you. Again, all those considerations for other unique aspects of your practice. Who should they call? Where should they go? What do you want done? I will say an interesting point about testing practices that has come up a few times. One question is, what if you're in the middle of a testing battery when something happens to you? Is there anyone who can pick it up from where you've left it off and finish it for you? What if you've written it but haven't delivered the feedback? What if you are halfway through data collection? What if all of these things? And most testing practice psychologists have said to me, like, no one could look at my scrawl and make sense of it enough to carry out a testing, a reliable testing assessment report. So what then? Well, some people choose to have the estate reimburse whatever the client has paid up to that point, so that the client can use the money to go and start over with someone else. So just think about what you want in all of these different circumstances that apply to you. And then think about the authority to act, business associate agreement, limited power of attorney, in addition, depending on what you want to ask of your executor. So how do you enable someone to do these things for you? Well, think about the will as a signed contract. You want to have an agreement, not a wish list, but an agreement about who is going to do this for you. and they are going to agree, and you're going to make arrangements for compensation if that is part of what you want to do. So you need to provide really detailed information about how to access all your things, but you want it to not be accessible to anybody else in the meantime who could get at this confidential information. So where do you put it? How do you give people access to the physical location? Where do you keep the keys to your office, to your cabinet, your file cabinet? Where is your paper calendar? Where do you keep that if you have one? Do you have a list of contacts somewhere? Where is that? The clinical records, where are they stored? Some people, again, often say, my current clients are here in the desk, but my past clients are in the garage or in the basement or in the storage unit down the street or whatever. That person needs to know where and how to access. Electronic access. So especially if you use an EHR, someone needs to know how to get that password. You are prompted to update that password all the time. Are you going to remember every time you're prompted that you need to change it on the list that you're leaving for someone? Because well-intentioned people might not be able to get in if they don't have the most current password. What about two-factor authentication, where they send a code to your phone and someone needs to get that code to log in? So even if they have the passwords, if two-factor authentication is enabled, someone won't be able to get in. If your calendar is online, your website, your voicemail, your email, all these things that have a place in the plan that you're going to change the messaging on or need to access, how will they be kept together? So what I recommend is that you consider using a password manager. What we use is a password manager that will keep it updated, only the accounts that the executor would ever need access to. You don't want it to have your bank account and your everything else on there, but only the necessary accounts. Keeps it up to date, can serve as a two-factor authenticator. So the code goes to the password manager. So you can have it anytime you need it on the password manager app, but so could your executor. If they needed to get in, they could get the password, the two-factor authenticator without having someone to find your phone and get the code. And the way we do it anyway, we don't have access. We don't want access unless necessary. So it's a private account. But often the password managers allow you to name someone as your emergency access contact. So if something happened to you, I would then initiate the emergency access protocol with the password manager. The password manager would try to reach you by phone or by email or text. They ping you. Do you want us to release your passwords to Dr. Miller? If you don't answer within the time period that you have set, which could be immediate, it could be 4 hours, 6 hours, 48 hours, whatever you want, but I typically recommend immediate so that we could get going with making those calls to your clients that are upcoming. But if you don't respond within that window of time, then they release the password. So then can go and log in as you and see your calendar and your contacts and your files. It's the most patient oriented way to handle this speedily. You also can, some of your EHRs allow you to name a legacy person or the person who would have access to your records if necessary. It's important to note that all of the EHRs, at least as far as I have encountered and understand, even if they have this feature, they will require a death certificate. So even if you file your professional will with them, at the time that you're trying to get in, they want a death certificate, which could take a week or 10 days, in which time you are not able to get in. And so the patients are not getting called. So that's why we do it the way we do it, getting your passwords and logging in as you so that we can most immediately notify clients. You do want to distribute your professional will to your personal representatives, certainly the practice executor, your attorney. You do want to think about your consent to treatment form. So I recommend saying something like, in case of an unexpected absence from practice, or you can spell out incapacitation or death, I have arranged for another licensed clinician to protect the confidentiality of my records and to notify my clients. So you may want to do that. Some folks, like, I don't know if you know of Tom Gutile, who is an ethicist, who is actually a psychiatrist. So his, I think, ethics codes maybe are a little bit different than ours. He says he personally doesn't feel that it's necessary or even beneficial for a patient to be required to sign a form at the very first session that alludes to his or her new psychiatrist's potential demise. So, that there's some truth to that too, but we take informed consent pretty seriously. So most people that I talk to do want to put something in their informed consent. Again, it's not required in order to access their records because you are appointed as the practice executor, you have that BAA, and in an emergency situation, everybody's just trying to do their best. Anyway, you may want to leave the funds and update your will periodically. I can't tell you how many people do tell me, like, oh, I have named as my executor this person from grad school, but I haven't talked to them in 10 years and I don't know where they live anymore. That, can happen. You want it to be up to date. And then we're going to talk about who. I am looking at the time. I think I'm going to just power through to the end and then we'll take all questions. We're about 20 minutes, half an hour. We'll save time at the end. Okay. So it was only possible that someone who knew you and was close to you and nearby you was your practice executor when we all only used paper. There needed to be your partner next door who could come into your office and find your paper calendar and get your paper records. It had to be someone local. So the model was developed by the San Diego Psychological Association that had kind of a bunch of therapist deaths at the same time. And I think this was in maybe the late 80s. And they created the concept of the professional will and the first template for it, which is actually the template that APA still uses, that's available. So that your colleague, someone that you know is your executor. That's how this works, that one-to-one. I'll do it for you if you do it for me. So if you choose to do it that way, there are a number of things to think about. One is, are they a good fit? Are they going to be someone you're going to feel comfortable just knowing that that responsibility resides in them? How close are you? You maybe want to be close because it gives you comfort to feel that someone who really knew you would be interacting with your clients. But you also have to realize the burden that you're putting on that person who would be mourning you at the same time, and whether or not it's really in the client's, your patient's best interests to have someone who is going to be grieving you be the person who is doing this. Can they really do it? Do they have time? Do they have availability? What if they're on vacation? What if, can they handle it? It's pretty urgent, at least the first part of the work, and time consuming. What's their personality style, clinical, cultural match? You may want to consider, what are their attitudes towards death, or their rituals or traditions, and are they different from yours? And is that a conversation you need to have about how, if or whether you want someone to sort of have a shared understanding of what death or this kind of interaction should look like. You want to think about how they feel to you, but you also want to think about how is that person going to mesh with your family, because they will be dealing with your family to resolve a lot of this. So that should influence your choice. And for access, your family will still probably need to be involved in some parts of the plan with a colleague. One therapist that I know was an executor for his sister, also a therapist, who died. He had to take 2 months off of his own practice because he was so overwhelmed both by grief and by the responsibilities of being her executor, that it wasn't, possible to see his own patients. Okay. Another option is a cooperative group agreement. So this is sharing the responsibility among a group of colleagues. I think this is better than the one-to-one. This is if you have a peer group and you want to say, hey, let's all share the responsibility if something happens to any one of us. So it spreads the burden, and people may have similar therapeutic style. You may be able to refer to one another. You really want to be sure to outline each person's unique needs. Practices run so differently behind the scenes. We all have our own little systems of how we do things, and nobody will be able to guess yours. People tell me I keep these on little note cards over here, but then I tally it up over here. And, it can be quite confusing to someone else to try to figure it out. So you want to know, and I have had a group tell me that they went on a field trip to each person's office to be able to see all together, like, here's where I keep my files, and here's where I have the key, and here's where so it needs to be pretty explicit. You still want to have an agreement and responsibilities. Who's going to do what for whom? Who's going to lead it? Who's going to be in charge? You want to identify, how are they going to communicate? Are they going to communicate by email? Or are they going to communicate by text? How do you protect patient confidentiality as they're doing that? There is a higher risk for violations of confidentiality, especially if you live and practice in a similar area, because you don't know whether your colleagues who you've now pulled into it might know your clients socially. So you may sort of encounter some kind of worlds colliding situation. And also, one issue is that things can fall through the cracks because everybody thinks someone else is doing it. Ann Steiner writes about this and has some good resources. She recommends appointing an emergency resource team of colleagues, and there is an identified bridge therapist as the main contact and coordinator. So there's a resource if you want to take a look at that. And this is where the talk ended in the past. these were the options. And so given the presentations that I would do up to this point, and then some writings that I did based on my experience with Dr. B, the reactions I got from colleagues were, oh my gosh, you're stressing me out. I don't know who would do this for me. I never thought about that. I don't know what to do. And so that did lead to the creation of a therapist professional executor service. So I will briefly tell you about that as one of the options. Tried to figure out all of the obstacles that I've been telling you today and how to solve for them in a more efficient and professional way that is, the hope is that it feels like your best friend is doing it for you without burdening your best friend at a time of loss. So that was the intention. So the idea is about outsourcing. We outsource our billing, we outsource our social media, we outsource, other things that we don't know how to do. We are not experts in law, we are not experts in planning. So how come this is a duty we all have, and yet we are all in our own offices trying to figure out how to do it? So how do we make it easier? So we have created a comprehensive attorney reviewed will, and then we alter that per your specifications, how you run your practice, what you would want in the event that something happened to you, among all the details that we've talked about. And that is done in an hour consultation with a clinician where we really want to understand how you operate, who you work with, how you work with them, what you want for them, what would need to happen. And it's a clinician who would be working with you and then working with your clients. We figure out a really clear plan for security of passwords and accounts. If you use paper, that's fine too, but we're going to have a good plan about how is that going to work. And we don't come to your office and take your paper records. They would have to be digitized, and that is not as complicated as it sounds. So I'm happy to answer any questions about how that works if you'd like. So the hope is that you have a very clear plan in place that covers your ethics and the laws of your jurisdiction. You control the costs, so it is similar to an insurance model where you pay now for the risk that something might happen, but then you're covered if it happens. So, all depends on your personal comfort and calculations. And it spares your family and colleagues. So briefly then on retainer after we put that plan together, and then if something happens, when we are notified that something happened, we step in and do all the things, including keeping the records for the duration, including talking to the clients and helping with referrals and transfer of care and all of those notification details that I outlined. Okay, so just to look at the pros and cons of the traditional model and the cooperative model. I think you understand how they work. They work differently. The pros, of course, are no upfront costs, the comfort of relying maybe on someone that you know, less burden in the group agreement. There are lots of cons. The traditional model, especially, it's really stressful, overwhelming. It's easy to avoid. Many of you will probably continue to, think I ought to do this for still a long time to come. And some of you hopefully will leave here today and do it. But it can feel quite overwhelming to figure this out yourself. Again, lawyers can be quite expensive. It is really important to remember, if you have an attorney draft a will for you, which is great, but it's only a piece of paper. It's not the who is going to do all these things written down on this piece of paper. Your attorney's not calling your clients. Your attorney is not keeping your records. Your attorney is charging you $1,500 to $3,000 to write your instructions. But who's going to do the job? And then we talked about some of the cons of the cooperative group agreement, including that you have to have a professional network. And unfortunately, a lot of people may not. And then our intention here, of course, we meet for a consultation, we determine your wishes, we create the will, we have the foolproof plan, the will's approved on retainer. The pros, controlling cost, a fail-safe plan, comprehensive, clinicians are ready to serve, you know, they're not going to be on vacation or unavailable. The intent is to let you practice stress-free and in good health for a long time, and just know that you're covered and your family and colleagues are spared if something were to happen. But the cons are that there is an upfront cost, and if you have paper records, they would need to be digitized. Okay, so no matter how you choose to do it, these are the options. And if you have another option, please write it in the chat or raise your hand, because I would love to hear other options if you have one, but not really been able to determine other options. So with the responsibility, taking care of this one way or another allows your clients to feel cared for and respected and supported. It allows them to walk away feeling like, I am so sad that I lost that really important person in my life who has been a wonderful support. And yeah, I might be devastated, but I believe, you know, therapy can be really healing, and I want to find someone else that I can, you know, do that work with when I'm ready, rather than the opposite of, you know, anger and feelings of betrayal. That internalization of the therapist as that good self-object remains intact, and, you know, people can continue with a sense of hope, and protecting your family and colleagues. So I did hear good stories, really lovely, nice stories sometimes from patients. One patient in particular told me that she had known the therapist was ill, but she seemed to be recovering, and then was quite surprised when she got a call from the therapist's colleague saying that she had died. But she said she felt the person calling was really compassionate, offered support, helped with referrals. The patient felt shocked. She felt very sad, but she said she felt that it was handled beautifully and she felt really cared for. That's what we're going for. In these circumstances, when there was time, which again is not always the case, but in those rare and lucky circumstances when someone had time and ability to offer a brief goodbye to their clients, that really makes a difference. Someone said of the therapist, it was very generous for the therapist to speak to her by phone. The patient said, now I know better how to face death myself. That, you know, they really were perceived as very gentle and kind and expansive. And the patients being able to say, thank you for what you have meant to me, what you have done for me, seems to be really part of a healing process for people if they have that opportunity, which of course we can't always provide. Folks were very, again, grateful to receive calls from attuned covering therapists who could tell them something of what had happened and who offered to meet with them or to connect them with another therapist. Again, when the therapist, when the patient surmised that the therapist had been organized and prepared, they really held the therapist in high esteem and felt good about their treatment despite the loss. Someone else talking about his therapist said he loved me. This was a therapist from long ago, and he was telling me a story as they were nearing termination, and the therapist went on vacation, and they resumed work after the vacation, and then the patient got a call where the therapist said he had been diagnosed with a terminal illness and he needed to stop the treatment. And the therapist said, he needed to work on his own situation. And the patient really respected that the therapist thought it was best to terminate rather than to try to continue. And the therapist encouraged the patient to see someone else to help him through what was happening. So before long, this patient, who was, again, a therapist himself, saw on a professional listserv that his therapist had died. And he said that at the memorial, which he went to, he listened to other people speak about the man, not only the therapist whom he had known, but the man. And this patient said that it was so reassuring to him. He felt that he had known the therapist really authentically as a very real human being in the way that people were speaking about him. He said, this was more difficult than the loss of my parents. Who knows you better than someone you've been talking to intimately for 8 years? I had expectations he would be there for me. I was devastated and overwhelmed. And he was tearful in sharing this story to me, again, many years after it had happened. And he said that he wished he had been able to see the therapist one last time. And he is one of the 6 who did make his own professional will, having had this experience. And he said he believed the important thing is that their suffering is minimized and not added to by negligence, so to speak, is what he said. So I really do hope that you hear all these examples almost as like a love letter to therapy. It is about the therapeutic bond and the intensity of it and the healing power of it. And it also is about, if we rely on the therapeutic bond to do good for our patients, if we think it's impactful and healing, then we have to also realize that it can have a detrimental effect if it's abruptly severed and not handled appropriately. And that, for the sake of those relationships, we have a responsibility to think about it. It will take you to a long list of reading materials, and there are some publicly available templates that you may use to create your own if you would like. The one that I had mentioned is available there, the San Diego one that the APA uses. I have not found a template that I think is comprehensive enough, so I did create a composite of a number of publicly available ones, and you can find that there. It is not the same one that we use, but it includes most of the information. And again, it's not legal advice, but for your education and reference of things to consider, you can get a professional will checklist, things to review, and that is how you can reach me if you would like to do so. And I am happy to look at the chat and to take any more questions that folks have.
It does seem like it is a question that says, is this service available for retirement as well?
Yes, it is.
Okay. Thank you.
Anybody
And someone
else?
just made a comment. You may see that she mentioned regarding the comment that you made that was a good idea to have a professional executor as her colleagues are who are her current executors. I'm assuming she's saying they're getting older, and many younger colleagues are still in the denial phase. So she appreciated that comment.
Thank you. I see about field trips. Yes, practice. Thank you, Ted. True. Anything else? Anybody else? Oh, wait, let me see. I'm looking up.
I just have a question. I saw this on a listserv. It was actually just yesterday or today, and they were saying that it's a somebody in another state, and they were saying that they often get called. Well, not often, but they receive several calls from family members of psychologists who have passed, and the family members are wondering, what do I do? So, is that part of it where you encourage the person to let your relatives know that this will exist, and how do you recommend that's handled?
Yeah, very important question. So, we are all about the proactive. We are about you as the therapist taking control, making the plan, laying the groundwork, having it set up so that it goes the way you would want it to. And you're encouraged to provide that document and that plan to your loved ones, to your lawyer, to certainly the person who's going to do it. Part of our process, we have folks name a personal representative and an alternate, and they are the people who are responsible with notifying us if something were to happen. So, we ask typically that it's someone within your immediate circle who would know quickly if something happened to you. People often say, well, could it be a colleague? It can be, but who's going to tell your colleague that something happened to you? Who's going to find out quickly and also still have presence of mind at a time of crisis to know they need to think about your practice and reach out to someone? And so then once we are notified, then we can kind of spring into action. So definitely recommend, however you do it, make sure your loved ones know your plan, that you introduce them or have some way of connecting them with the person who's going to be doing these things for you, that everybody's on board. You may want to include in your personal will something that says, I have created a professional will that designates Dr. Miller to be the professional who will execute my professional responsibilities related to my practice, so that it's referenced in both places. And then the question about family, pretty sure I know what state that is. It can remain nameless, but I have gotten a number of calls from people within one state, including being in touch with the psych association there, as they are trying to field calls from, I think my mom has dementia and is still practicing. What do I do? To my spouse has a terminal illness and what can we do? To my colleague suddenly died and what do we do? So those questions come up and will come up more often, as boomers are aging. And so it is really important to have a plan in place. We want to be able to help, but like I said, we work in creating that plan. So we have the authorization and the information and the access and the instructions of the therapist ahead of time. And we have worked with some of those families to provide them with the information that they need and some other resources with how to kind of handle the responsibility that has fallen into their lap.
Thank you for that, Dr. Miller. Any other questions? Oh, Jed.
So I'm going to go back to the kind of the field trip question, and I love that example, as I noted in the comment. It's kind of we learn how to do the awful dreaded thing by periodically practicing the awful dreaded thing. So, do you have a recommendation about how often, if we do have an identified executor or group, how often we would kind of walk through the process with each other, just so that we keep this information in our heads?
I'm not sure what I can recommend. My reaction, my smile is like, nobody's going to do it. Even if I gave you a good recommendation, no one is going to, on a regular basis, talk with their friend about what happens if they die.
Fair enough.
But let's do it at least once, and maybe once every year or two or three or four. Certainly, as you have life stage changes, to be sure that it's still appropriate what you want and who would do it.
Very good. Thank you.
So I'm gonna ask a question too. Um, you had mentioned, as far as the testing issues and stuff like that, if you have a more testing practice versus clients, therapeutic practice. Oh, I can't get the words out today. I was wondering then, with this service, is there like different price levels depending on the amount of clients a certain person may have in their practice or type of client?
So I don't want to get into the details of cost and so forth in this talk. I really want it to be about the ethics and the different solution options, but I am more than happy to answer you if you'd like to reach out to me directly or check out the website.
I do have a question, Dr. Miller. You may have addressed this, so my apologies if I missed it. For people who are part of a group practice, do you sometimes recommend like there being a process for the group and everybody that's a part of the group, rather than working with people one-on-one?
So group practices are they require some thinking in a little bit of a different way, or on a number of different topics. So the will is generally intended to be for one therapist and their patients, how their patients are taken care of and how their records are taken care of. In a group practice, let's say there's 5 clinicians and everybody has their own, clients, but the records for everybody are kept in one place, electronically or in paper on site. And let's say it's the owner, though, if there's one owner, if there's two, or, it depends on the structure of the entity. But we do get a lot of folks there's one owner, there are maybe 4 contract therapists who work for them. And the owner, part of, so we don't do the succession planning about what happens to the business exactly, but it is part of the conversation to like at least help the therapist begin to think about, because the plan would be different in different scenarios. So, for example, I'm going to ask someone, have you thought about whether you would want your employees to just be able to take their clients and take the records and continue seeing them and set up their own practice if something were to happen to you, so the practice dissolves? Or do you want to see if the employees want to buy the practice? Or do you want your estate to try to sell the practice? All those options, and usually people don't know what they want and haven't really thought about it, but those are all things to consider. It's much easier if you want it to disband, then we're just going to talk about what to do for your clients and your records, and we're going to appoint somebody else in that practice to help with the administrative matters of dissolving the actual practice. But everybody knows then what's going to happen with at least the current patients and their records. But there needs to be still a plan for who's going to hold the past records, who's responsible for those. You have to think through that. If somebody wants to try to sell the practice, even if that's like just a vague thought in their mind, then we want to put a plan in place for how could the practice be stable for at least some short period of time, 1 month, 3 months, while the family then is in contact with a business attorney and a broker and trying to figure out how to sell the practice, which again is beyond me. But they need time for the other staff members to be able to continue to see their clients, for the doors to stay open of the practice. So I'm going to ask them, okay, which staff member do you think would best be able to take on some more of the administrative responsibilities? Is there someone who you want to say should be the clinical supervisor if you aren't able to do that? Is there someone who should have access to payroll so that everybody else can still get paid if something happens to you? Someone who would pay the rent? Whatever needs to happen so that the practice can kind of at least just be stable enough until the estate then decides what they're going to do with it. And so we're going to make that kind of plan. So it depends on what the circumstance, and again, in that kind of situation, most group practice owners who intend to sell the practice say to me, I don't need you to call my patients or refer them. Somebody within my practice can call them and my practice will absorb them, but can you take the records for the practice? Or, and again, this depends on the laws where you live. Some go with the sale, some states prohibit records going with the sale without the client's consent. So some of those details I think are beyond me, really.
Okay, thank you.
Yeah.
Any other questions? No other questions from the audience. You all, please, if you have any other questions, please chime in. I just want, because we had I think a few students on here today, Dr. Miller, and for people who are in maybe graduate school or about to graduate within a couple of years, I'm just wondering, what do you think? What is your message to them? What is your message to people who are on here who supervise students and interns? Should this be a part of conversations at that level of training?
Absolutely. I love it when young practitioners, students, or early career folks are thinking about this issue. It is so important. It is not an issue for the elderly. As I shared, my young and vibrant and beautiful friend and colleague, you would never have guessed, in the world that this was, around the corner for her. So we just don't know. And I think if you understand that this is really a clinical responsibility, it's part of setting up a good frame for your practice from the beginning of your practice. It's not something that you just ignore until you feel fragile as you get older. It's really something that, could affect any of us and affects our clients. And so I appreciate your interest and hope you'll, talk to your friends about, how important it is to think about this from the start.
I love that somebody mentioned that she's, I think Sabine, hopefully I'm pronouncing your name correctly, that she's mentioned the need for professional wills in her lectures to graduate students. Oh, very good. Not sure if they are ready to hear that at this stage of their professional journey, however. Yeah. Yeah. It's tough to wrap their mind around at that stage. Yeah. Any other questions or
I
comments?
cannot tell you. It's really not about age. I cannot tell you how
Okay.
many much elderly folks when I am at conferences kind of look at me like, don't talk to me. I will come to you one day when I'm closer to death. And some like really aggressively, I do not want to think about what you are talking about. Somebody joked like, if I am dead on the floor, then you can, talk to me.
Wow.
You know.
Wow. And Mara says definitely not about age. Her financial planner has been bullying her to make a
Yeah,
professional will. You've been
exactly.
bullied around this. Okay.
Well,
Yeah.
Thank you for listening, and I really appreciate the chance to talk with you. And I very much appreciate you guys mostly keeping your cameras on and being engaged. That makes it a lot nicer to talk. So thank you.
Awesome. Well, thank you for your time, Dr. Miller. We appreciate that. Yeah, excellent presentation. People are saying we learned a lot. I really do think it may be kind of unprecedented, this kind of presentation at this length for ArPA, at least for a while. We may have talked about it some years ago, but just in my time, I think this has been kind of a new conversation for us to have as a professional organization. So thank you for providing that information. For people that are on, please, if you don't already follow ArPA on LinkedIn, on Facebook, on Instagram, please do. We have already been putting information out about this topic, and also Dr. Miller and TheraClosure, the partnership there with TheraClosure. We've been putting that on our website and our social media platforms. So please check that out, and also we'll also have some upcoming posts after today. Just as housekeeping, I just want to share you have received an email regarding, I'm just gonna, if you can stop sharing your screen, if you don't mind, Dr. Miller, and then I just want to share something. Thank you.
Oh,
Thank you. I saw you had your website up there and contact information, so hopefully people receive that. Please know that her slides, I did put those in the chat. If you did not see them or if you did not get them, please send an email to office@arpasite.org, and I'll be sure to get those handouts to you if you didn't receive them today. I just want to share my screen because you probably receive an email. It should look like this, that thanks you for attending today. You probably received it maybe just a couple of minutes ago. Sometimes they come out in batches. If you all did not receive them at the same time, they sometimes have to come out in batches. But please complete your evaluation form. That does help us. So it'll say that you can just click on it and complete it. That helps us in the PDC, the Professional Development Committee, kind of keep in mind how you receive the presentations and what to think about for future presentations. You should also receive an email for checking out. Just in case you don't, Judd, if you don't mind putting that checkout link in the chat, just so people can see that. But you should have received an email. That is the best way. If you did receive the email, please do it that way. That will ensure you get your CE certificate for today. So please check your emails and complete it. You'll probably have to put in your email address again just to be sure you receive your certificate. Okay, those are the main, I think those are the items that I have. Judd, you can let me know if I'm forgetting anything. Okay, thank you. Judd put in the generic checkout link, so that's a backup link, but certainly please check your email first. And just keep an eye out for upcoming events. Actually, the Professional Development Committee, we have several members. Feel free to raise your hand of the committee. Thank you to all. Judd, who is on, Tisha, Mara, Margaret, Pat. We have several, hopefully I'm not missing anybody. There's Tisha, who have helped in the planning of everything for today. And then, so keep an eye out for our lunch and learns. We do have a lunch and learn on April the 15th. Regarding prescription privileges, and just for us to think about that and be able to have conversations. Mara, you can help me with the name. There's going to be some folks from APA, I think Deborah Baker, and all the other names.
Beth Lonning.
Okay, Beth Lonning. Okay, thank you. And so all of that is also on our website and on our social media platforms. So if you haven't already registered for that, please do so. That is free to our members. And then we are planning our fall conference. So keep an eye out for that for the save the date. I think that's everything. That's everything. I don't think I missed anything. Okay. Thank you all. Again, please, I'm just going to keep the Zoom up for a little bit so people can have that checkout link if they need it. So yeah, Tisha says, please come and join the conversation in April, no matter what you think about prescription privileges. Please, please, please.